Hi everyone, your Optum coach this side, and today we will be discussing the anatomy of the orbit. So we will be covering orbit in different videos, which will include the following topics. This video is about the introduction to the. So the orbital cavities are a pair of large bony sockets that house and protect the eyeballs, their associated muscles, nerves, vessels, and fat, and most of the ocular appendages and lacrimal apparatus. The bony orbits are a pear-shaped structure, and its apex, which is this part, is directed posteriorly, medially, and slightly upward. So this is an MCQ point. The stalk of the pear lying within the optic canal. This is the optic canal. The bony orbits are situated between the anterior cranial fossa above and maxillary sinuses below. They are separated from each other by the nasal cavity and ethmoid and sphenoidal air sinuses. Each orbit is roughly the shape of a quadrilateral pyramid. So anteriorly it is of a shape of a quadrilateral pyramid whose base is the orbital margin. This is the orbital margin, and the apex narrows at the optic canal. This here is the apex. The floor tapers off before reaching the apex. Therefore, the apex of the pyramid is triangular in shape. The orbits are surrounded all round by bones except on the outer side. The orbital aperture is directed forwards, laterally, and slightly downwards. So this is another MCQ point, which is a characteristic of primates and indeed predators who require binocular vision. Now these are all MCQ points that are coming. The vertical height of the orbit in adult is 35 mm. The horizontal dimension in an adult is 40 mm. The depth of the orbit is 45 mm. Volume of the orbit is 30 ml, while the volume of the globe is only 6.5 ml. The orbit is widest approximately 1 centimeter behind the orbital margin and not at the margin itself. So suppose this is our orbit. So it is widest 1 centimeter behind the orbital margin. So it will be widest here. The orbit consists of 4 walls and 4 margins which are located anterior to the walls. The constituents of the wall and margin are different. So this is another point that you have to keep in mind. The orbit is lined by periorbita that continues with periosteum of the skull and face. Besides, there are various fascias in the orbit that divide the orbit into 4 surgical spaces. So this will be another video. Nerves and muscles passing from the apex into the orbit pass forward and laterally. The intraorbital width, that is distance between the two medial walls, is 25 mm, and the extraorbital width, that is the distance between the right and the left lateral orbital margins, is 100 mm. The relationship between the height and width of the orbit is expressed by orbital index, which is height divided by width into 100. The index shows racial. Races having an orbital index of more than 89 are termed megasense, between 83 and 89 are termed mesosense, and less than 83 are termed as microsense. Now coming to the relations of the bony orbit, as we know that there are 4 walls, that is the roof, the medial wall, the floor, and the lateral wall. We'll be now discussing the relations of the bony orbit. So, superior to the roof lies the frontal air sinuses. Occasionally, ethmoid air cells also invade the roof, meninges, and the frontal lobe of cerebral hemisphere. Inferior to the floor lies the maxillary air sinus, infraorbital nerve, and blood vessels within the infraorbital canal. The lateral wall separates the orbital cavity anteriorly from the temporal fossa and posteriorly from the middle cranial fossa, the meninges, the temporal lobe of the cerebral hemisphere. And the medial wall separates the orbital cavity from the ethmoid sinuses, anterior portion of the sphenoid sinus, and the optic canal. So what forms the orbit? Which bones form the orbit? So there are 7 bones. Another MCQ point. The part of the following bones contribute to the walls of the orbit. These are the frontal bone, the zygomatic bone, the maxillary bone, the ethmoid bone, the sphenoid bone, the lacrimal, and the palatine bone. Orbit has 4 walls. Another question. There is a roof, a floor, a medial wall, and the lateral wall. The medial wall runs antero-posteriorly parallel to the sagittal plane. So these are parallel. The lateral walls diverge at an angle of about 45 degrees to the medial wall. The lateral walls of the 2 orbits are at a 90-degree angle. So the lateral walls are at a 90-degree angle with each other and a 45-degree angle with the medial wall. The orbit has the following foramina and fissures. These are superior orbital fissure, inferior orbital fissure, optic canal, nasolacrimal canal, anterior ethmoidal foramina, posterior ethmoidal foramina, zygomaticofacial canal, and zygomaticotemporal canal. The orbit has the following contents. It has the globe, the muscles, the cranial nerves, branches of the ophthalmic artery, superior and inferior ophthalmic veins, branches of sympathetic chain, the ciliary ganglion, the orbital fat, the orbital fascia. It is to be remembered that there are no formed lymphatics in the orbit, most of the lacrimal apparatus. All these things will be discussed in detail in further videos. So this is just a brief as to what all we'll be discussing in the future. So coming to the surgical spaces, various fascias in the orbit divide the orbit into 4 separate surgical spaces. And these spaces are subperiosteal or subperiorbital space, the peripheral or extraconal space, the central or intraconal space, and subtenons or episcleral space. We'll be discussing this in detail in another video. Now coming to the changes from pediatric to the adult orbit. These are all MCQ points, that's why it's quite crowded. So at birth, the orbital cavities are relatively large. The margins are ossified and strong so that they protect the eyeballs during parturition. The volume of the orbit in a newborn is about 10 cc, which doubles by the first year. The orbital entrance is almost circular at birth, developing a horizontal oval shape as the child turns into an adult. In the young child, the orbital cavities look more laterally than do those in an adult. The supraorbital notch is situated more laterally in a child. The lacrimal fossa is deeper than in adults and faces more anteriorly. In the child, the distances between the orbits are small and they move apart later. Now why does that happen is because at birth only ethmoidal sinus is present and all other paranasal sinuses develop later. So when the frontal sinuses develop and they expand, that is when the orbits they move apart. The superior and inferior orbital fissures are wider in a child and later become narrow due to the growth of the greater wing of sphenoid. The angle between the orbit changes from 71 degrees at birth to 68 degrees in adult. In old age, bony absorption occurs and this may result in holes appearing in the roof, the lateral wall, and the medial wall. In elderly adults, the orbital septum often weakens, particularly in the medial inferior area, which may cause herniation of fat and loose connective tissue. Thank you for watching my video and do subscribe to my channel for more such videos. Thank you.